Alright, hey guys, it's Jamie. I'm one of the current second years, upcoming third years. I'm going to talk to you about oliguria or low urine output in the postoperative patient. This is something that you'll get paged about probably at least once a night when you're on call. This patient's urine output dropped off, this patient hasn't voided since their Foley came out, etc., etc. So by definition, oliguria is less than 400 to 500 cc's per day or about 20 cc's per hour. I usually like to see like 30 cc's per hour, but they will only kind of measure per hour, usually in the ICU. Otherwise, it's just Q shift. If a patient is bigger or smaller, if you have your old tiny lady, her urine output may be lower based on her weight. Anuria, by definition, is less than 100 cc's per day, and decreased urine output usually is not a concern unless acute renal failure is also present. What is acute renal failure? It's a significant decrease, greater than 50% in GFR with associated accumulation of nitrogen wastes like BUN and creatinine in the body. The creatinine provides the most accurate and consistent estimation, and there's kind of a debate about the definition. It says an increase by greater than 0.5, some say greater than 0.3 in 24 hours, some say greater than 50%. Just kind of in general, look, is it trending up? Is it higher? Significantly higher, what's their baseline, kind of go back in their labs from, the previous year and see where they actually hang out. Early sign of acute renal failure is decreased urine output, but this is only seen in about 2/3 of patients. So etiology, you have your pre-renal, intrinsic, and post-renal. Pre-renal is going to be the most common, about 70%, and even more so common in our patient population. When you get kidney hyperperfusion due to an absolute decrease in blood volume from something like dehydration, bleeding, GI losses, NG tube, diarrhea, decreased PO intake, a relative decrease in blood volume like sepsis, some certain drugs, and renal artery stenosis. Intrinsic is when you get parenchymal injury due to acute glomerulonephritis, interstitial nephritis, or acute tubular necrosis from certain drugs or toxins. Post-renal would be obstruction due to a stone, a tumor, an obstructed Foley catheter. So you'll get paged a lot saying, we took this person's Foley out 8 hours ago, they have not voided. What we do is have them bladder scan and possibly straight cath, but you always want to know, is there urine in there to come out, or are they just dehydrated and they don't have the urge to urinate because they just don't have enough urine in their bladder yet. Most common causes: sepsis, major surgery, hypovolemia, low cardiac output, nephrotoxic agents, increased intra-abdominal pressure, or abdominal compartment syndrome, cardiopulmonary bypass, trauma, and rhabdomyolysis. So the most common ones that we'll see, obviously, would be major surgery, hypovolemia, and sepsis. Postoperatively, it's not uncommon for a patient to have decreased urine output. Can be from fluid or blood loss. Obviously, you can look back at the operative notes, see what was the blood loss. If it was significant, we usually sign that out to each other. If they had a really long surgery, long open surgery, you get a lot of insensible losses from that. Response of the adrenal cortex is stressed. You get increased aldosterone release in the first 24 hours, increased ADH release, which results in salt and water retention. This is temporary, should not last more than 24 hours. All right, so you get the page, they call you, they say, patient's urine output's dropped off, they've only made 100 cc's of urine in the last shift. Just some tips of things to do: review the patient, how long have they been here, have they had surgery, why are they here, what are their medical problems, are they on a diet, are they on IV fluids, just kind of review them in whole. Also want to assess for urgent resuscitation, so just get in the habit of, if they page you about something, obviously if it's very insignificant, you don't have to do this, but ask them what's their blood pressure, what's their heart rate. Kind of can tell you, is this patient very hypovolemic? Could they possibly be bleeding? Is this someone that you need to get up there right away and see? Some questions to consider: does the patient have any symptoms or predisposing conditions that suggest hypovolemia? So have they been having diarrhea? Have they been throwing up? Do they have an NG in? How much is coming out? Are they on a diet? Have they actually been taking in their diet? Are they on IV fluids? How much? Is it appropriate for their size? If they're a post-op patient, you want to worry about bleeding. Do they have a JP drain? If they're bleeding, you should see it in their JP drain, oftentimes. Having any drainage from their wound? Could they have an infection leading to sepsis? Do they have fever, etc.? Does the patient have symptoms to suggest bladder outlet obstruction? Do they have history of prostate problems? Do they have a Foley? A Foley should have a constant stream of urine. If a nurse calls you and says, oh, there's been 0 urine output in the past 6 hours, well, no, you don't. Patients don't just drop off to 0. There should be something coming out. So they need to irrigate it. They need to maybe even bladder scan them, see if it's accumulating in their bladder. If they haven't voided since removal, like we talked about, we usually have them bladder scan them. If it's greater than 300, go ahead, straight cath. If it's less than 300, I usually ask them to page me back to give them some fluids likely. Is the patient likely to be suffering from acute renal failure? Do they have a history of renal failure? Do they have a big surgery? Do they have sepsis? Do they have kind of a reason that this could be going on? Are they on any nephrotoxic drugs? Any NSAIDs? We use Toradol a lot for pain control postoperatively. Those are things you want to think about and be able to stop. Did they have exposure to nephrotoxic agents like IV contrast? Did they have a CT in the past couple of days? And then do they have any underlying diseases that could kind of result or contribute to their oliguria, like cardiac failure or cirrhosis? So laboratory data here at Mount Carmel, we usually get daily labs, not saying that it's right or wrong, but they should have daily labs. Look at their hemoglobin. Has it been trending down? What's their baseline? The creatinine been trending up? Also, what's their baseline? And then you can always send a urinalysis if you're concerned for a possible UTI. Usually won't be faulted for ordering repeat labs, so early on I would order repeat labs on patients a lot, just to kind of see what their creatinine is. If they have decreased urine output, and you see that their creatinine is up higher, I'd usually be more aggressive with my fluids. If they're having a little bit of decreased urine output, but their creatinine is still the same, you still want to give them IV fluids, but may not be as worried about it, especially in your patients that have like CHF or you're kind of worried about volume overloading them. Also can help you see your hemoglobin, worry about bleeding. And I can say that I don't think I've ever been yelled at for ordering repeat labs kind of in the evening when I'm on call for a certain reason, as long as you have a reason to kind of back it up. So management, you want to review their ins and outs and their overall I's and O's. Kind of take a close look at if they have voids recorded. Sometimes I can throw off your ins and outs because they don't put the volume in. Do they have an NG? What's coming out of that? All their different drains, etc., etc. Review their medication, stop any nephrotoxic drugs. Review their home meds, see if they're on diuretics. Sometimes patients come in on high-dose diuretics every day. We don't continue them the first post-operative day just because of what happens post-operatively. And then some patients, sometimes their urine output drops off because they're kind of dependent on their diuretics. May need to place a Foley if the patient does not already have one, if they have a significant increase in their creatinine and their urine output's decreased. I'll usually place a Foley, probably run it by your senior, or if they haven't voided after their catheter's been removed, I usually straight cath them twice and then I put a Foley in. Then pretty much the next minute you're going to assume that this is pre-renal and you want to do a fluid challenge. So you usually start with 500 cc's to a liter and will likely need to repeat it because only 20 to 25% of infused crystalloids remain in the intravascular space. So I like to kind of either through the nurse or physically assess the patient. Are they old? Are they young? If it's a young patient and they're healthy, you can just give them a liter bolus. I believe they do it over an hour, half hour, or an hour, and they'll be fine. If it's an older patient, if they have CHF, you may want to consider giving them, either 500 cc's first, or sometimes I'll give them, 500 cc's over 2 hours. You also kind of want to assess, do they look fluid overloaded? Are they on oxygen? Do they have crackles? Because sometimes these patients, it's very rare. I would say 95% of the time it's going to be, you just need to give them fluid. But sometimes it's a complex picture where, they are having shortness of breath or they're having increased oxygen requirements, but they're also having decreased urine output. Kind of what do you do then? That's kind of a get your senior moment. Does this patient need Lasix? Or are we just going to give them fluid because that's what they need? If they're septic, that's what they need. And you're going to have to deal with what happens with their respiratory status. So important points. Always review the patient. Go see them if possible. Why are they here? Their history. Have they had surgery? Their ins and outs, their labs, their meds, etc., etc. If it's associated with other symptoms and signs suggestive of fluid depletion, you should treat this initially with a fluid challenge. So most pages you get about this will be treated with a fluid challenge. Important to exclude obstruction of the urinary tract or urinary catheter. So have them bladder scan them, have them flush it if there's concerns that maybe the catheter is not functioning properly. Make sure they're on their home flow max if that's what they take at home. And then always make sure you follow up, make sure their urine output improves. A lot of times on the floor, they aren't going to check again until the end of the next shift or 4 hours, however it's ordered. So you kind of want to go by, take a look that they're fully bagged, see how much is in there, and then, make sure that they respond. All right, that's it for that. Thanks for watching.